There's this multi-year progression of metabolic dysfunction that accumulates over time. Once you actually get the full-fledged diagnosis of something like type 2 diabetes, which is kind of like the behemoth in the room that you progress towards when you think about metabolic health. Despite throwing weight loss at it, despite throwing changes in diet, medications, you can achieve something called remission. But a lot of people don't actually achieve what is arguably the same metabolic health as someone who has not accumulated that damage over time. What you should learn from that is that you should do something now to improve your overall health. The day for action was yesterday, but every day you do improve metabolic health is a day earned because it is meaningful to do it earlier rather than later. In the literature, it's very clear that low carbohydrate is one lever to pull, meaning just reducing carbohydrates lower than the average intake, essentially less than 130 grams per day, can be a very powerful therapeutic tool. It's used therapeutically in prediabetes, obesity, and a number of other contexts. But when you really see a reliable improvement, it's usually because they went to the ketogenic diet spectrum. At least from the literature I have seen over the last 15 years on the ketogenic diet and or low carbohydrate diets, the ketogenic diet is a much more reliable way to induce the therapeutic benefits people think they're going to achieve when they lower carbohydrates.
Andrew, when you see somebody's metabolic health begin to decline, what are the biggest factors that are usually at play there?
Really depends on the person and their situation. Usually it's symptoms, right? No one really cares about their metabolic health unless they feel different, right? Or they perform differently in life. And so usually it's more of symptom presentation that usually demonstrates that there's something underlying that symptom. And in the context of type 1 diabetes, which I have, the cornerstone of that is glycemic control and insulin. And you can monitor that 24/7, 7 days a week, every day of your life. And that can give you profound insights into your metabolic health and the implications those two metrics can have on your overall health. But what we learn in type 1 diabetes certainly translates to other populations. And so your question is an interesting one, but it's very nuanced.
Okay, so what you're saying is the fluctuations in blood glucose is what you honed in on. That would be influenced primarily by diet. So that would be the factor we're starting with here.
Diet is a huge contributing factor, maybe one of the largest we could talk about, frankly, that ultimately affects someone's internal metabolic status. Your metabolic status obviously implicates your overall metabolic health. And so diet has a keen role in overall health and wellness. And the two metrics we talked about already, glycemic control and insulin, have profound impact on one's health, longevity, the implications and risk for comorbidities like cardiovascular disease. And so these are really important metrics to focus on. And it's something I'm very, very passionate about because I live this every day as someone who monitors it 24/7.
So in a practical sense, again, coming back to our factors, insulin and blood glucose fluctuations, zooming back, what diet are we talking about here is best for regulating those?
Well, so we can go right to like a controversial statement. I could say, well, low carb diets are the best for controlling glycemic control and lowering insulin. And that would certainly make some people's heads explode. But the reality is that there's some real science behind that statement, but let's unpack that a bit more. So when someone says, what's the optimal diet? Well, the optimal diet is certainly one in which you as a person thrive on that diet. Okay. So if you were to, by chance, happen to do a very low carbohydrate diet and you didn't feel great, the question would be, well, one, are you doing the diet wrong? So that's the first thing you have to unpack. But maybe you are one of these outliers where you're not responding well to that diet. Maybe you need to try something else. The same applies to all diets. There's also individual considerations culturally, personal level. What are the environmental constraints that help or deteriorate your ability to ultimately comply with a diet like this? And so there's a number of factors that are at play, but one diet that we pay a lot of attention to because of its profound therapeutic impact, particularly on glucose and insulin, is these very low carbohydrate diets, where we have largely reframed the terminology around that to be therapeutic carbohydrate reduction. Because a lot of people view the terms of low carbohydrate, that could mean anything to someone. It could mean, okay, some people think they're doing a low carbohydrate diet by just eating less than 225 grams of carbohydrates per day. Whereas, if you eat 224 grams of carbohydrates, are you really low carbohydrate? No, not by definitions, not by any definition, frankly, that is established by experts. But doesn't mean that there isn't confusion around those terms. So we have recently proposed some consensus guidelines around how someone defines these diets. And those are usually based around the carbohydrate intake of those diets, because the carbohydrate intake has a direct impact on internal metabolism and then overall implications in therapeutic potential of those diets.
Okay, well, let's take an example here. Somebody that hasn't been paying attention to their carbohydrate intake, say they're doing that 225 or beyond, and they've been doing that for a period of time. Their metabolic health has been slipping. Let's get into physiology and talk about over years what's happening, and then we'll work our way back.
Sure. So usually one of the bigger levers in the context of metabolic health one has to consider, and I say lever is something that can be changed, right? Is body weight. So number one, if someone's able to regulate their body weight, that's a really important metric on overall metabolic health. So if someone's an excess body weight, regardless of what diet you're doing, that is going to have negative direct impact on metabolic health. This is why drugs like GLP-1 receptor agonists have had such a massive splash on the global metabolic health scape, so to speak. Eli Lilly and Novo Nordisk are the two biggest producer of these drugs, and they are certainly reached a profit margin that is unprecedented recently due to the amount of people who struggle with obesity or overweight, or one of the conditions that results or is contributed to by obesity and or being overweight. So weight is one important factor to consider right out the gate. And obviously, when we talk about diet has a really powerful impact on diet. There's a lot of people who say you can't outrun a bad diet, right? And there's some absolute truth to that, because a lot of times in the literature, when someone just exercises more, they tend to compensate by consuming more calories. So without adjusting diet as a fundamental premise of any therapy, including GLP-1 receptor agonists, at the core of how those drugs work is ultimately facilitating caloric reduction. If someone did not undergo caloric reduction on GLP-1 receptor agonists, they're likely not going to achieve anywhere near the therapeutic benefits that have been described in the literature associated with those. So that's one key pillar to focus on when we think about overall health, is weight. Secondary to that is other more nuanced factors, such as insulin or the presence of potential insulin resistance. Insulin at high, more chronic levels, elevated levels, can ultimately be a sign of insulin resistance. Most people are not really able to do a gold standard assessment of insulin resistance using these techniques called insulin clamps. But what they are looking at are things like fasting insulin levels or HOMA-IR scores, which is a measure of insulin resistance. HOMA-IR meaning insulin resistance. These scores can give you an indication or surrogate marker, a marker that's not direct, but gives you a strong indication of where you stand on your overall insulin sensitivity. Tertiary to that, or maybe in many cases actually more important than insulin, is glycemic control. If someone has deterioration in glycemic control, this is a very strong indicator and early sign of underlying metabolic dysfunction. Outside of type 1 diabetes, because I have type 1 diabetes, that's a unique case where you can learn a lot from it. But we're going to talk outside of the scope of type 1 diabetes for a moment here. In populations outside of type 1, in type 1, you don't have any insulin being produced. You exogenously administer it, so it's a unique outlier example. But in normal populations, pre-diabetes, type 2 diabetes, the elevation of glucose, even subtle levels, can indicate early changes that are signs of things like insulin resistance. And this can give you an early indicator that you may be on track for something like a future diagnosis of diabetes. Diabetes is not just a snap of the finger overnight diagnosis. It's something that progresses over time. So tertiary to both weight and or insulin resistance is also the presence of dysglycemia as a key metric. Now, I say it tertiary because usually insulin resistance is happening first, and then you can see signs of dysglycemia second to that. Although there's not a lot of good metrics that people at home can measure for insulin, so a lot of people focus on glycemic control because you can get there's a lot of advanced tools that have come from advanced technological advancements for diseases like type 1 diabetes that are now available for the general population, like finger stick monitoring for glucose, continuous glucose monitoring, which is now publicly available through companies like Abbott and Dexcom and beyond. And there's a whole host of many other metrics that someone can consider in their overall health. How much are you exercising per day? That's a really important consideration to one's overall health, independent of weight. So if one's exercising and you keep the weight absolutely stable, just the presence of exercise, independent of any change in weight, has a profound impact on overall health. Sleep has a major impact on health as well, where we show clear signs that, well, first, most people are not sleeping well. And most people don't realize they're not sleeping well either. And sleep deprivation or less than optimal levels of sleep can contribute to a whole host of subtle changes that accumulate over time that lead to poor health. And all these things intermingle together. And so when we talk about the key pillars of health, which is, I kind of think at the core of what you're getting at here, there is nutrition, exercise, and sleep. Other factors like society, social health, stress, other factors that are underlying a lot of that or contribute to it. And then you can look at key metrics that we talked about, like your overall weight, your insulin levels, glycemic control, amongst many other biomarkers that may be beyond that are more nuanced to someone's particular case. And so that's how I would look at that. And when someone thinks about, quote, metabolic health, because we're talking about metabolism and how metabolism impacts health.
Coming back to the weight piece and connecting that to insulin resistance, how do you look at that from a chicken and egg perspective? Somebody who is becoming more insulin resistant, which can happen over a lot of years, and slowly gaining weight over that period of time. You talked about the connection there, but does one usually occur before the other?
Well, there's a whole host of competing opinions around this. I think the traditional theorem or dogma around this was that elevation in body weight due to excess caloric intake and reduced physical activity contributes to excess weight accumulation. Excess weight accumulation can contribute to more adipocytes, larger adipocytes, excess inflammation within the body. This plus other factors contribute ultimately to this end result of the cells, particularly these muscle cells, because insulin works at various tissues, but one of the largest sinks for glucose that insulin helps facilitate glucose uptake into is the muscle. And so when we talk about insulin resistance, we're really talking about peripheral insulin resistance at the muscle. And so when we see early signs, and this has been shown across a number of scientific models, that inflammation could impair the ability for insulin to facilitate its signal to open up glucose to enter the cell. And when it can't do that, where else is it going to go? It obviously could go to fat and accumulate as more adipocytes because you have excess. And there's only so much that can, in theory, be stored in the muscle as glycogen or be utilized as energy in those tissues. So that's where I would say is the underlying theorem. However, there's a lot of controversy. There's a publication that came out no less than 2 weeks ago where they challenge the idea that inflammation is inherent or guaranteed to precede the development of insulin resistance. Maybe it's contributory, but maybe not causal. There's other theorems around the idea that someone's dysglycemia can actually contribute to the elevation in food intake, amongst the array of other things that are going on. Excess accumulation of body weight due to excess calories can ultimately cause insulin resistance. So, and there's other divergent models, the calorie in, calorie out model. There's the carbohydrate insulin model. And really, in theory, there are divergent theorems. But the reality is that from a practical sense, when someone's actually at let's say, Jess, at home, you're trying to think, how do I actually improve my metabolic health? These models really don't matter. What actually matters to you, Jess, at your home and how you feel is that you are able to live a lifestyle that facilitates the key changes in how you feel and ultimate key metrics in overall health, weight, glycemic control, insulin, and beyond. Um, and all that reflects how, at the end of the day, a quality of life factor. So I think these theories are important to the underlying, I guess, mental nuance that people love to debate around. But the reality is that you need to do an intervention that allows you to facilitate the changes, sustainable changes, Jess, as well, because that being a big problem with any intervention. I could go tell you to not eat anything for a week and do that every other week, but you may look at me a little crazy and say, well, I can't keep that up. And I would say, you're probably right, you can't. It would certainly work, but it's not sustainable. So anything you do has to be maintained as well. And I think that's important to acknowledge anytime we're speaking about overall change and lifestyle change for overall health. So,
well, I think why mechanisms in testing, you talked about home IR and fasting insulin, why they're so important is because with this degradation of metabolic health, it happens over such a long period of time, and the symptoms are going to slowly come on in the frog in boiling water kind of concept, where people likely are going to make that their new normal as they're degrading over the years. So understanding what we're talking about here, knowing objective testing they can have done as they go along can motivate them before they get all the way down to, say, type 2 diabetes, and their metabolic machinery is been in disarray for years.
yes, Jess, so you bring up a very interesting point. So there's been extreme controversy over some of these metabolic monitoring tools, one of those being continuous glucose monitoring, and their use in the general public outside of populations with diabetes. But you bring up a salient point that in a disease like I have, where type 1 diabetes, where you have access, on my phone, I have 24-hour glucose and insulin all day, every day. And so I can chronically monitor key insights into my overall health, well-being, and ultimately predict what my chronic health and well-being will be, what my risk for comorbidities would be, what my risk for overall longevity, or not my risk, but my overall lifespan prediction. But what do you do when you don't have that? What do you do when you don't have that 24-hour insight, that direct response and feedback around how your body's responding to food? You're blind. A lot of people don't have the advanced knowledge that you would have, Jess, or many others who are maybe more motivated in trying to understand their overall health. Many people are left without these tools. And are just Googling ad libitum, trying to find something to improve their health. And usually they fall prey to scams, things that are largely non-effective. Hey, take this bottle of pills over here that's going to dramatically improve your glycemic control. I saw this the other day. A friend of mine sent me a text showing me a new product that came out. I'm not going to call anything out or anyone out, but suffice it to say, nothing in there was doing what the label was claiming to do. And this is the same as when I was a kid. Before I got any advanced degrees in this or had any kind of expertise in metabolic health, I was an obese kid. And in adolescence, I fit the obese category. I definitely was obese. It wasn't like I was a big bone kid who, I was very strong and all those other things, but I was definitely overweight. I had excess adiposity. I was fat, Jess. So, and I remember walking down the aisles thinking, like, what's the solution to this? Because everything I tried isn't working. And you find these like fat loss pills. And God forbid I actually would have taken one of those things and the impact it could have had on my overall health. But suffice it to say, that is the unfortunate reality for many people. Now, there are some extremely potent and powerful drugs that are available for people. The underlying problem with that is that many of those are certainly helpful in moving the needle. The problem being is that they also can make it potentially complicated for someone to understand how to make sustainable lifestyle changes without being reliant on these tools or medications in perpetuity. When people think about health, I think about health, people say, let me back up for a second and say this differently. Just people say food is medicine. I've said this for years. I believe in that deeply. Exercise is medicine. I've heard that for years. I also believe it deeply. But there's something else that can be stated around these. It's not so much that these are medicine. These are foundational pillars of health. And in medicine is the practice and treatment of symptoms and disease. It isn't necessarily the treatment of health, although it clearly is. But what the reality of that practice is ultimately the treatment of alterations to overall health. So when we talk about food and we talk about exercise, these are important, just fundamentals to living a well-lived, healthy life. The absence of well-formulated nutrition, the absence of routine exercise practice, good sleep, reductions in stress, or maintenance of a balance in stress within life, that then leads to disease, or often leads to disease. Certainly can contribute to poor health. And so, yes, these are medical tools, and they are powerful medical tools. Sometimes food and exercise are more powerful than medications can be. And this has been known for many, many years. In fact, there was a recent study that had focused on psychological health, or the impact that exercise in comparison to drugs have on things like depression or anxiety. And exercise beat all of the common drugs utilized for those maladies or mental disorders. And a lot can be learned from that, because those are diseases that are largely treated at first glance with medication, or there's obviously cognitive behavioral therapy and other interventions. But medication is a commonly, if not the most commonly utilized intervention for those alterations or disorders. Whereas exercise requires effort, but is more effective. And we know that exercise or physical activity is something that our biology is made and programmed to do. And its absence chronically, i.e. sedentary lifestyle, certainly causes deterioration in health. And anyone who's trying to live a well-lived, high quality of life is certainly going to need to, one, have good, appropriate nutrition within the caloric balance of an appropriate body weight, ideally whole foods, limiting processed foods. Two, exercise on a regular basis of a minimum of probably 30 minutes per day, even if it's just walking. But anything is better than nothing, and more is better than less as a general for exercise. More intense is better than less intense. Although, work your way up. Don't just go, if you sit on the couch for 2 years straight, don't just go up and do sprints. That might not be your best move. But yeah, these are important things as someone who has, one, lived with a chronic disease in type 1 diabetes, a metabolic disease where at its core, 99% of patients have dysglycemia, and all patients are believed to have insulin resistance just due to the way in which insulin is administered in the body. But also someone who's keenly interested on optimal performance, both cognitively and physically. Not only do I care about that deeply on a personal level, but I also have researched it, and I also have worked with elite level performers. And everyone wants to feel the same. They want to feel great. They want to perform well. And metabolism and overall metabolic health is a key pillar of that. And a lot of things we talked about leading up to this are important levers to pull when trying to optimize that, but also key metrics that need to be tracked over time to see where you stand and how you may improve upon your overall health.
As you talked about your friend texting you that bogus product, it got me thinking about even great products used incorrectly could do harm to people, including a CGM, where tying that to the conversation we've had thus far, metabolic health, where somebody could be using that, getting data on their blood glucose and feel like they're doing great. But we know, and I want to get into this in greater detail with you, the fact that the insulin in the body is going to ramp up over time and mask certain changes in blood glucose. So you might be missing a lot of what we're talking about today with insulin resistance for a period of time, just looking at your blood glucose when your body is endogenously ramping up insulin and masking a bigger issue.
Yeah. So Jess, this is something that I've talked about with many people, both researchers, companies trying to develop products that are trying to improve and ultimately monitor health. There's a big lesson that can be learned in all of these because there's a lot of interest in glucose for important reasons. It's, you maintain this really tight level of 70 to 120 milligrams per deciliter, which is around 3.9 to 4.5 to 6.5 millimoles per mole, millimolars, depending on what metric you use. When you go outside of that, even subtly over chronic periods of time, it can have impacts on your overall health. But what is underappreciated is exactly what you said, which is if I were to go eat food, a lot of times the overall impact on metabolism is not fully observed. So I see it because I have to administer a certain amount of insulin to control for it. So I'm seeing exact quantities of insulin being administered. So the other day is a great example. I recently was on an 11-day cross-country tour with my family. My wife, 2 boys, our dog. I didn't have like readily access to a gym. Like I have a home gym, but I didn't have access to go like do a 1 hour plus workout, super hardcore, high intensity. Like I just did whatever I could. And a lot of times that was nothing more than moving around and focusing on them and this adventure with them. And so I looked at my insulin and I could see over time, while my glycemic control, my mean glucose was exactly the same, my insulin levels started to creep up because I was less physically active. Whereas the average person, their body initially would be able to compensate. They wouldn't see changes in glycemia, even with these advanced tools, at least initially. But then you would start seeing underlying elevations in insulin. We don't have a 24-hour insulin monitor. If we did, someone would be making billions of dollars right now, Jess. I can promise you that, because that is the one thing missing for everyone else. This is why people with type 1 diabetes have such unique insight into their overall metabolic health and in metabolic health in general, is because you are monitoring insulin and glucose 24/7. In my opinion, those are the 2 most important metrics in quantifying or assessing where you might be in your overall metabolic health. And changes in either of these over time, not only are they predictive of chronic disease, but they're also early signs and indicators of subtle changes within your biology that may lead to more impactful changes. So you are correct. Most people have no awareness of what's happening on insulin. And most of these lab values that you go and get are usually observed once, if you're lucky, every 6 months. Most people are doing it maybe at max once a year. And that's a single snapshot at a single moment on your overall health. And I would argue this is insufficient to really optimize your health. You would certainly want greater levels of resolution on your health over a period of time, of which a lot of people don't have. And a lot of people don't even know that they should be doing these things.
Let's try and get as most upstream as we can here. You talked about earlier the fact there's inflammation, problems with insulin at the muscle level, and then extra energy being deposited into fat cells. I just want to make sure I understand where all this begins. With somebody having, say, too many carbohydrates or sugars, those fluctuations in blood glucose, insulin coming into the picture, how long does it take, and what are those first steps where things start to go awry?
So there's actually a great paper written by, or an overview by a gentleman named Jim Johnson, where he attempted to highlight another article and look at the kind of trajectory, the hypothesized trajectory of some of the key underlying metabolic changes that occur. The summary of that at a 30,000 foot level that would be relevant to your audience listening to this is that these are changes that occur over years. They're not happening immediately. You can see immediate signs of this over time, and there's clear lifestyle changes that would put you at a greater risk. But these are things that happen over a chronic period of time. There's some literature that would suggest that things like prediabetes, progressing to type 2 diabetes, is a multi-year process. Some would throw a generic term of, let's say, 5 years, but that number is meaningless on an individual level because it's all depends on family history and your risk and what your lifestyle looks like, how active, inactive, body weight, all these other things, right? So, but it's a multi-year process. It's a multi-year process that once is achieved, and I wouldn't say this is an achievement, this is an achievement you want to get. If you get type 2 diabetes eventually, a lot of people, even despite throwing all medications at it, all lifestyle interventions at type 2 diabetes, can achieve something called remission. So to your question, Jess, there's this multi-year progression of metabolic dysfunction that accumulates over time. Once you actually get the full-fledged diagnosis of something like type 2 diabetes, which is kind of like the behemoth in the room that you progress towards when you think about metabolic health. Because when you have something like obesity that's rampant, not just in the United States, but many developed countries and beyond, that then eventually leads, what's the next layer of obesity? Well, the next layer of obesity is type 2 diabetes. That is the more progressive, more dangerous chronic disease that it often results from, at least in part, due to accumulation in obesity. Not always, but commonly. And this development of diabetes over time, again, multi-year over time, you have normal metabolic health, you have pre-diabetes, and you get type 2 diabetes. Once you get to type 2 diabetes, despite throwing weight loss at it, despite throwing changes in diet, medications, you can throw all these things at it, and you can achieve something called remission. But a lot of people don't actually achieve what is arguably the same metabolic health as someone who has not accumulated that damage over time. This is something we see in type 1 diabetes, so another form of diabetes, where there's something called metabolic memory, where the accumulation of damage is not forgotten. Okay, it's just like smoking or sun exposure. You don't get skin cancer the first day you walk outside and get sun. You don't get lung cancer the first day you smoke a cigarette. It's usually the accumulation over time and total volume over your lifespan that is most predictive of your risk for getting any one of these conditions. The same appears to be the case with overall metabolic damage. We know that things like elevation in glucose levels can have a direct impact on oxidative stress and inflammation, and alters certain other pathways that are largely irrelevant to your audience, like aldose pathways and whatnot. But there's clear and known pathways by which elevated and variable glucose levels can ultimately facilitate damage on tissues at the cellular level. Obviously, over time, that can accumulate to accumulated damage that ultimately leads to damage to tissues and tissue function. Then with insulin, this is another thing that we can learn, again, from the disease of type 1 diabetes, where most people are normal weight, or at least used to be normal weight, but they have to administer insulin in the peripheral tissue. So I have on the back of my arm here an insulin pump. This insulin pump administers insulin into my subcutaneous tissues that absorbed into circulation. It's hypersaturating my peripheral tissue. So what does that mean for most people? Well, Jess, I assume you don't have type 1 diabetes. And if you don't have type 1 diabetes, when you eat, let's say you went to the store and ate a donut, don't recommend this, but if you did, you would have this giant elevation in glucose, very rapid. Your beta cells in your pancreas would detect the elevation in glucose and immediately dump a dose-dependent and proportional response in insulin to cover that glucose, to bring glucose into the normal homeostatic range. In doing so, the body is ultimately responding to a glycemic challenge. Now, that insulin is in someone like you, Jess, who doesn't have type 1 diabetes. Most of that insulin is actually captured at the liver first. The liver will see that insulin first from the pancreas, and the liver will bind, or the insulin will bind the liver and store that as glycogen in the liver, because that's an important survival mechanism if you need to release glucose if you're hypoglycemic. So it's an important survival mechanism there. And it will also release it in response to stress, like say during very intense exercise. The analogy people use is if you're running away from a dinosaur, you want to spill excess nutrients into the blood to be utilized as energy. So that's an important primary mechanism for where to store glucose. So most of the insulin is initially bound to the liver and then ultimately stores glucose there first. Then the remainder of the insulin goes to the periphery. But what happens in type 2 diabetes is insulin resistance is not per se it is a function of potential insulin resistance to the liver, but it's much more a metric of insulin resistance at the muscle. Things that correct insulin resistance, like exercise, are changing insulin resistance at the muscle. And so in type 1 diabetes, what we can learn is that just by administering high levels of insulin in the periphery, so it's instead it doesn't go straight to the liver, it actually starts in the periphery, you have this elevated level of insulin. And the elevated level of insulin in the periphery causes insulin resistance in people despite not having all the developed metabolic damage of type 2 diabetes. So what that also shows is just the mere presence of excess insulin in the periphery can result in insulin resistance. And I'm sure most of your audience can do a quick Google search of insulin resistance and related disease risk and can find the accumulated damage that elevated insulin can have. In the short term, elevated insulin can contribute to things like elevated blood pressure. It's certainly the impact of insulin is underappreciated in the brain. It does go to the brain and actually causes neurobiological and systemic metabolic changes. I know for myself, as someone with a lived experience of type 1 diabetes, the administration of insulin, I can literally feel when the insulin levels are higher on a neurological, on a perceptual level. I can feel the elevated level of insulin. I can tell when I have levels of high levels of resistance to insulin. So I need more insulin for the same amount of insulin, a glucose challenge. And suffice to say, it doesn't feel better. It feels worse. Most people wouldn't consider themselves thriving by having to administer higher levels of insulin. At least for myself, I find that I can feel more lethargic, less energetic, and it doesn't give you that feeling of thriving. So, to your original question, all the way back to when you asked, what is the accumulation over time of this disease, or what's the progression? It's a multi-year process that ultimately facilitates key changes in biological effects like elevated and variable glucose levels, elevated insulin levels, and others that are often as a result of elevated glucose and insulin that can damage key tissues over time, leading to the development of things like type 2 diabetes that ultimately is not apparently completely reversible, despite doing almost everything and throwing all medications at it and lifestyle changes at it. The only thing that appears to put type 2 diabetes reliably into remission is weight loss, sustained weight loss. The problem is that in the absence of the sustained weight loss, you do not retain remission. And remission is largely defined by an HbA1c level. So meaning, how are you diagnosed with diabetes? You're diagnosed with a glycemic value, Jess. You're diagnosed with typically with an HbA1c value in excess of 6.4. Early signs of diabetes risk are seen anywhere from higher than 5.7 or 5.7 all the way to 6.4. That's pre-diabetes range. And then 6.5 or higher is diagnosis of type 2 diabetes, amongst things like elevated fasting glucose, an impaired or glucose tolerance test, and other. There's other ways of assessing besides HbA1c. Either way, once you meet that criteria, usually you have accumulated damage over time that's been multi-year, that is accumulated at a cellular level that appears to have memory that's not completely reversible, i.e. like smoking and sun exposure due to other diseases like lung cancer and skin cancer.
All right, a lot there, a lot we can dive further into. Starting with this irreversible damage piece, which a lot of people are talking about metabolic health, insulin resistance, diabetes, but I haven't really heard this piece of pushing to a certain extent with insulin resistance and then creating damage we can't reverse. So for somebody right now who is somewhere in the middle of, say, the continuum of being insulin resistant, they're not type 2 diabetic, but they've been pushing it for a number of years, blood sugar fluctuations, insulin rising, they have an extra 20, 30 pounds around their belly. At that point, have they done irreversible damage, or do they have to go all the way to being type 2 diabetic before they get to the point of no return?
Well, Jess, I think it's important for your audience to understand why I said what I said. What is the evidence for anything I'm saying here? The evidence is that there have been a number of key studies where individuals have gone on therapy, got their biomarkers into quote unquote ideal range, but yet they don't appear to have the same overall health as someone else. So meaning, and a great example is something called the DCC and EDIC trials, the Diabetes Complication and Control Trial. I forget, I'm actually butchering that, but the DCC and EDIC trial and type 1 diabetes. It was the largest funded trial in NIH history for type 1 diabetes. Over 1,000 individuals with type 1 diabetes over time. All they did was administer more insulin over a multi-year, it was 8 years for the initial study, and looked at chronic complications. So that's the ultimate end metric that people want to see. Do you change actual disease risk on onset or mortality? And those are the most important ones. Like, you can change biomarkers all you want, and that's important. But what's even more important is, did you actually change the incidence of real disease manifestation or early onset mortality? And so what they did is they assessed individuals over time trying to achieve better glycemic control. And what they found is that the cohort that had better glycemic control had much less complications, microvascular complications, macrovascular complications, and beyond. When they realized the profound difference in complications, showing a causal relationship between glycemic control and micro and macrovascular disease in diabetes, it also, so as an ethics and research, when you see something like that, you usually stop the trial early, or you stop as early as you find a meaningful difference that would have clinical meaningful differences. But what they did is they actually continued the trial and put the other group who had been on had worse glycemic control, and they were doing less intensive intervention to improve the glycemic control with diabetes. They then put that cohort on the other intervention the other cohort was on, meaning one cohort went with the intervention, the other one did nothing. And then when they got the stopping point, when they found these massive clinical differences between these two groups, they put the control group on the intervention that the other group had already been on. And what they found is they, despite achieving similar glycemic control over time, could not reduce the risk for chronic complications and comorbidities. That meant that group had accumulated metabolic memory and damage that was not completely reversible. It meant that despite them eventually correcting, when they realized it, their glycemic control using an intervention that helped improve glycemic control, they could not actually reduce the risk for chronic micro and macrovascular disease to the equivalent level of the other group. So that early 8 years of damage in this specific study was non-reversible, at least not completely reversible within the context of that study. But let me back up for a second, Jess, and say, someone may hear that and say, well, I've been type 2 for 20 years, I've had high and variable glucose levels with type 1. Like, why should I even try now if it's already accumulated? That is a terrible philosophy. You should absolutely, what you should learn from that is that you should do something now to improve your overall health. Like, you should not wait. Waiting is not an option. The day for action was yesterday to improving overall health. But every day you do improve metabolic health is a day earned. Okay. It's not a day lost. And so the lesson should be there, not to be discouraged, but actually to be encouraged to do something now, because it is meaningful to do it earlier rather than later.
And I would assume, given what you just said there, take action right away. For that person who has suffered irreversible metabolic damage, it just might mean overall their diet would be lower carb throughout the rest of their life versus somebody who didn't suffer that damage, or exercises in a different way, or sleeps better. I hate to go down this rabbit hole because all of us should be doing the best we can, even people that aren't metabolically irreversibly damaged. But just like yourself, somebody with type 1, you have a chronic disease now, and it just influences the way you behave with these different diet and lifestyle behaviors day in, day out. So somebody with this other metabolic damage would just likely have to make different choices moving forward.
Correct. Yes. And for my particular circumstance, we know that in the context of diabetes, it's definitely for sure in type 1, but in many studies in type 2 as well, that glycemic control is the predominant risk factor for the number one killer in these disease, was cardiovascular disease. And so what do? I look at the literature and the scientific literature and I say, what is the most important thing I can change over time? And almost universally, the evidence says improving glycemic control is the way to do that first. It's analogous to trying to improve a car. You focus on the engine. If the engine is non-operational, it is irrelevant. Okay, you don't focus on the tire pressure if the engine doesn't work. You don't care about that. And so that's engine is glycemic control in that context. But then you start going down other risk factors. You can look at things like risk, blood pressure, lipids, particularly triglycerides in the context of diabetes, certain medications that can help over time. A lot of these studies haven't really assessed physical activity and sleep, although if they were assessed, I assume they would be pretty important predictors of overall health and disease risk. But you focus on the key hierarchical, most impactful risk factors in this disease over time. And then you go down the list. So for me, I have done a low carbohydrate ketogenic diet to manage my type 1 diabetes for over a decade. In fact, I've studied myself. We had 2 publications that came out that it was a unique opportunity because I have controlled my body weight, my physical activity, my diabetes management had remained consistent for over a decade, and I had followed this diet, gone from the American Diabetes Association recommended diet and switched over to a ketogenic diet. Both were whole foods. I had the same level of activity and same type of activity over that same period of time. And ultimately assessed my personal cardiovascular health, early signs of atherosclerosis, but also looked at long-term chronic well-being, signs of deterioration health, things that people had hypothesized would cause adverse health outcomes, like elevated LDL and beyond. Because I had a very high elevated LDL. That'd be the one thing that people would look at and say, that's going to lead to elevated risk for cardiovascular disease. The whole point of me saying this is to say, I focus on the most important biomarkers in the literature that show risk associated with the diseases and complications that matter to me. And by following the science on this and using evidence-based strategies to focus on what's most important versus least important, in this particular study, my risk for cardiovascular disease, not only was it lower than for the average person in type 1 diabetes, if you match the sex and age, you match almost all variables, but it's actually lower than many people without diabetes at all, because we did cross comparison to other non-type 1 or non-diseased individuals. So in this case, I was able to, at least for myself, and it's only a single case, so take it with a grain of salt, but use this philosophy and ultimately translate it to what appear to be meaningful, positive outcomes in overall health. And you're right in that each person may have to approach this slightly differently. We know that the low carbohydrate interventions can be some of the most, if not the most potent interventions, dietarily speaking, to managing diabetes as a disease. But there are a number of other interventions that may be context dependent. Maybe you have a metabolic alteration, or contraindication is a term used in medical literature for someone who cannot follow a specific diet. And there are some for things like low carbohydrate ketogenic diet. They're not very common, but they do exist. And so then that person has to consider a different path on their journey. Maybe they have an alteration in their underlying metabolism, doesn't allow them to metabolize fat, whatever it could be, right? And so they have to do something slightly differently. Maybe this person is juggling a number of other family-related challenges. Maybe their job is very demanding. They have to work night shift, and at least in the short term, that's their obligation. That's what they have to do. And both of those things would certainly potentially have a risk for adverse or overall health, or impacts on that person's overall health. And let's say you're, a firefighter. Let's say they are a firefighter in this context, and they may not be able to exercise whenever they want at this perfect circadian timing, and they may not get perfect sleep. Well, that doesn't mean you don't do anything. You just do what you can, right? You do as much as you can when you can. And so when I became a father a little over 5 years ago, I have a 2 and a 5-year-old. Exercise was no longer waking up and done on a set schedule in this perfect environment with this unlimited amounts of time in the gym. I was very constrained to when and where I could do it and however I can do it. And I made the most of that. And doing something was better than nothing, and doing more was better than less. But yes, there's a lot of context to each person and their own individual circumstance that they all have to consider on their journey. And we all know that on a biological level, we're all very, very similar, Jess. But there are some subtle differences across all of us, even on a genetic level, but certainly on an environmental level, that ultimately influence how we're going to respond to something or a specific intervention. And that has to be taken into account. That's why there are a number of different tools in the toolbox when managing metabolic disease. We talk about something like a low carbohydrate ketogenic diet. That's an incredibly powerful tool in the toolbox, if not the most in some contexts. But there are other tools that need to be considered, and because that tool may not apply for all, or it may not be optimal for all or available for all in the same way.
Given what you know going through your health journey with type 1 diabetes, being a scientist and this being your job, digging into the research and continuing to learn, hypothetically, how different do you think your diet and lifestyle would be if you weren't type 1 diabetic? You mentioned the ketogenic diet. We're getting an idea of the healthy lifestyle you live. You're prioritizing exercise and sleep. Without type 1 diabetes, do you think your lifestyle would be the same? And I want to ask that from the perspective of course, you might not have learned all the things that you learned because of your health journey. You've gone deep into it, and you can expand upon whether or not that's influenced your career path. But if you had the knowledge you have now, you weren't type 1 diabetic, would you still live the lifestyle the way you do?
No one has ever asked me that question before. That's an amazing question. I think I would be lying if I said yes. There is no way that my diagnosis did not have a profound impact on my life trajectory. Profound. I believe that my diagnosis was not it was devastating at the moment I realized it, and led to depression and for a number of weeks. It became the best asset outside of my family and my life. And that drove me to self-experiment and gain knowledge on a level that I would have never done if I didn't have this disease. So you asked a unique question, though. You asked if I had all the knowledge I have now, would I still do what I'm doing? What I would do potentially differently is everything about lifestyle, exercise, sleep, all those things would be the same. The one thing that I think may be slightly different is diet. In the context of type 1 diabetes, carbohydrates are not your friend. They are absolutely not your friend. They lead to, typically, depending on the carbohydrate, most of the carbohydrate you find in the grocery store would lead to elevation, high and variable glucose levels. And the insulins I currently have available for type 1 diabetes are not fast enough to even remotely capture the kinetics of glucose influx from digestion of carbohydrates, oral carbohydrates. It's about a 3 to 4 fold difference in the speed. Carbohydrates peak at 30 minutes in insulin demand, whereas the fastest insulin delivery occurs with exogenous insulin in type 1 diabetes is 3 to 4 times slower than that. So carbohydrates are not my friend in that context. What I would potentially consider is a diet that liberated, I liberated carbohydrates to the degree to which I was able to regulate my overall health. So I like this statement, and this is not to be dogmatic around any particular diet being optimal or not. Each person's got to find that on their own. There are many different diets for different use cases. But particularly in the context of the diseases and metabolic challenges most people encounter in today's society, like obesity, being overweight and obese, and diabetes, ultimately usually coming after that, or in subsequent to those diagnoses or initiation of things like overweight and obesity, I would be extremely keen on finding interventions that help me, one, maintain body weight with minimal effort. So I was obese. So you said if I didn't have type 1 diabetes, but I was obese at one point. And so assuming I didn't remove that factor either, what I had to do to regulate weight, I tried every diet under the sun, Jess, with or without type 1 diabetes, by the way. And the one diet that helped me regulate my appetite the most was the diet that removed a lot of the hyperpalatable foods within the food environment, focused on whole foods. And that had profound impact on the way I felt and my ability to regulate appetite. Because I'm someone who had obesity in adolescence. I mean, I'm the ultimate risk for someone to have chronic, not major obesity in adulthood in today's society. And I don't, because I worked my ass off to find a solution that worked. And ultimately, the thing I've sustained over time that has worked for me is the very low carbohydrate diet, because it removes a lot of the things that for me are very difficult to regulate appetite. If I go to the store and eat a bag of Doritos, like, I don't want to eat one. Okay. I could use willpower to eat one, but that willpower is limited. You have to use tools that reliably allow you to not have to fight your biology at each step along the way. So I think diet would be the one thing that may change, because assuming I still had the insights of the impact on glycemic control and someone invented a continuous insulin monitor, and I could see the direct impact on what I was doing every day on insulin, it would be a hard case not to consider the same strategy I'm already doing. And I would have tried it, and I would have seen if it was optimal for my life. And at this stage, as a parent with very variable schedule, I don't have a consistent schedule. It's not a thing. And a lot of demands in different areas, particularly to be a parent, a good husband, before doing anything else. And then there's science after that. Man, you have me really thinking here, Jess, but I think that I would have no doubt focused on whole food based approaches. I would have prioritized protein. I would have then considered where I place the other energy from other whole food sources to determine what I felt best on. And I feel great right now on a very low carbohydrate approach, but I'm also living in a disease where it makes it very, very clear that if you input a bunch of carbohydrates, it's near an impossibility to reliably manage glycemic control without a ton of effort. And I don't want to put a ton of effort into my disease. I want to live an optimal life and minimize the impact the disease has on my life in any negative way. So, yeah, I would do everything the same, but I would reconsider things outside of protein and what I would prioritize based on how I felt, because I assume that I might have some subtle differences in how I feel without this disease, because in type 1 diabetes, you're a hyper responder to food. So when you eat carbohydrates, you spike higher in glucose than someone without it. When you eat protein, you have higher glycemic impacts because you have elevated chronic, something called hypergluconemia. So when you eat protein, that can trigger glucagon, which can then trigger an elevation in blood glucose. Well, in type 1 diabetes, you have elevated basal and postprandial glucagon. And as a result, you become a hyper responder to anytime you consume anything for elevations in glucose. And so I wonder if I would have the same type of response to these foods. And it's impossible to say. A lot of people thrive on these approaches. I've seen a lot of elite level performers choose this lifestyle due to its ability and ease to minimize the noise in their life around food. That's huge. I mean, that's what these GLP-1 receptor agonists are doing for a lot of people. They're removing the food noise that can honestly be, for some people, be 24/7. And for me, having obesity as a kid, it probably would be. So I would do whatever it took to remove that from being a chronic part of my life so I can see clearer and focus on things more important than what am I eating in the next minute or two. Great question, though, Jess. I've never had anyone ask me that.
All right. Slight pivot, another thought experiment. I'm sure there's a number of people listening and watching that have type 1, but I'm sure there's a lot more that are on that spectrum of insulin resistance all the way to type 2. In your case, ketogenic diet with insulin as needed to manage blood glucose. How different would diet and lifestyle look, prescriptive-wise, for a type 2 diabetic, assuming they're not on insulin, versus what you're doing?
Well, I wouldn't say very different at all if they wanted to do this intervention. What I do particularly now in my specific life is very specific to my schedule, my needs, and the things I want to remove as barriers in my life. Like, I don't wake up and immediately eat a meal. I don't want to think about food when I first wake up. I'll have coffee and focus on other things in my life until I actually get hungry or after I work out. So my specific case is it might be particularly unique in that I've adapted it over time to what really works for me, and everyone does that too, to be frank, or should do that over time. You don't just pull up a book that says this is how you follow this diet and not continually improve and adapt and iterate on it to optimize and tailor it for yourself. But would their diet be that different? No, I don't think so. I think that people should be focusing on protein first. I think they should be focusing on ways to incorporate nutrients that are whole foods, minimizing foods that make it incredibly hard to control appetite like hyper-processed foods. This combination of various, you can look at the back of a bacon packet and people add sugar to that. You can look at the back of a bar of peanut butter and they add sugar to that. Like these combinations of sugar with fat can be hyper palatable tools that are utilized to make people overconsume these food products. And so I would just say whole food based approach, protein focused, and then how you lay out your nutrients, macronutrients are dependent on how you can help yourself remove barriers to caloric regulation. And for me, I find that a lot of people really benefit from minimizing food intake around when they're already not hungry. Like, let's say there's a certain window of the day based on, let's say you wake up and you're not hungry. A lot of people, that's the case. That's when they're least hungry. Whereas some people, it might be later in the day or during work. Well, that's a great opportunity to reduce calories when you're inherently not already hungry. That's not a time to like just throw a meal in there just because you have to. Those are opportunities to have what they call low hanging fruit. Like, hey, there's this, I'm not hungry from this window to this window every single day. Okay, chop that low hanging fruit off and you leverage that strategy. And just use that window to not consume food then. And when you are super hungry, that's when you can have your meals or plan your meals accordingly. You can also leverage your lifestyle around exercise to be during windows when, like I find that if I wake up first thing in the morning and exercise, that's good and well, but I have to be careful with what I consume after that because if I eat some even if it's a low carbohydrate snack and it has all these like artificial sweeteners and crap in it, with some artificial sweeteners being far superior than others, there are natural sweeteners that I think can have a pretty potent and beneficial metabolic effect compared to others. That can trigger hunger for a lot of people. And then you're basically introducing challenges to yourself. You have this acute positive response to the food, but then you basically give yourself a whole day's worth of challenge thinking about food and battling appetite. And so, no, I don't think it would be different. I think everyone should be utilizing a protein focused. Well, the vast majority of people, when they think about a low carbohydrate based approach, should be, for the most part, making sure they hit minimums and optimal levels of protein, usually, although there's nuance in that. And then how you make up the remaining levels of calories, typically from fat and fibrous carbohydrates, would be around when it works for your schedule and ultimately how it helps you ensure compliance and remove barriers to staying on the diet and not feeling hungry 24/7.
Okay, let's zone in on the carb piece. We know overall you're a fan of low carb. You mentioned the fact that you're a fan of ketogenic and that's the diet you abide by. How does somebody decide whether low carb is enough versus ketogenic when it comes to a reversal of metabolic disease and maintenance?
Yeah, so I'll just say, I like to think of myself. People, if someone Googles me, they're certainly going to think I'm a huge advocate for low carb or ketogenic diets for sure. However, I'm not necessarily an advocate for anything but what works. And what works for many of these cases is these carb restricted strategies. This is evidence based. You can also do low fat if it works for you. There's evidence around that too for some individuals. There's Mediterranean. There's all these other things, right? But everyone's going to find what works for them. But at what point would you lower carbohydrates to the point of becoming ketogenic? Well, there's a lot of reason. The number one reason someone would do that is disease. So if you find that your disease is positively impacted from elevations in ketone levels, these could be a lot of neurological disorders or mental health disorders. At least there's this whole emergent field of metabolic psychiatry around the regulation of ketones and brain energy metabolism. That might be a case for when ketones are particularly important, the elevation of those. When you go from low carb to ketogenic, beyond disease, there's other potential cases for why you would do that as well. But to describe why someone would do that, let's break apart the key difference between low carbohydrate and ketogenic diets. Low carbohydrate diets are defined as a consumption of carbohydrates between 10 and 25% of total calories from carbohydrates, typically associated with 51 to 130 grams of carbohydrates per day. That's low carb. Ketogenic is typically less than 10% of total calories from carbohydrates, or less than 50 grams of carbohydrates per day, ultimately defined by the elevation in circulating ketone bodies above normal fasting values, which I would argue that you don't reliably see elevation in fasting, at least 24, like overnight fast, of greater than 0.3 millimolar on a standard diet. So greater than 0.3 is typically this tipping point by when you tend to be in an observed level of ketosis that's not typically observed outside of that context. What distinguishes these two diets? Well, there's actually an important difference between these two. Number one, the key distinguishable factor of the elevation in ketone bodies only occurs on a very low carbohydrate ketogenic diet if insulin is low enough to induce a widespread metabolic change. And that's not universally observed in low carb diets where carbohydrates are reduced, but not reduced less than 50 grams per day. What is the key difference? Insulin. Insulin is not reliably lowered significantly across diets that are low carb versus not, or lower carb versus not in this low carbohydrate category. Sometimes it is in the literature and sometimes it's not, i.e., it's not reliably lowering insulin sufficient to induce an elevation of fat oxidation and ultimately ketone production. Whereas the ketogenic diet, by definition, is the elevation of ketone bodies, which only occurs with sufficient reductions in insulin. The sufficient reduction in insulin induces a widespread alteration in metabolism, lowering the use of glucose and shifting towards an elevation in fat oxidation as a much more predominant form of fuel in the body. That induces a widespread cascade of metabolic changes, Jess. And that is a key distinguishing phenotype from low carb. Now, we talked about how the elevation in ketone bodies can have therapeutic application in a number of contexts. In fact, this is what I did for almost a decade, is study how just applying ketones through various tools like exogenous ketone bodies using novel formulations could ultimately have therapeutic benefit. And it does in a lot of contexts. It's particularly in this early stage investigations where we're at, where a lot of this was studied in animals initially and ultimately started to be studied in humans. And that work has really taken and just blown up over the last 5 to 10 years. We now know that ketones can be very important for chronic heart failure, an incredibly important fuel for the heart, Alzheimer's, cognitive decline, many, again, neurological disorders, seizures. This may be important and relevant. But when would it potentially not matter? Well, if someone is able to reduce their caloric intake, let's say obesity, if someone's able to reduce their carbohydrates sufficiently to induce a caloric restriction that allows them to lose body weight, but they don't need to go less than 50 grams per day, and that's what works for them, awesome. Then why change what works? You don't need to change what works. But if you want to achieve the elevation in ketone bodies, have much lower levels of insulin, increased fat oxidation, and all the related effects that phenotype can have, then yeah, you would have to go low enough in carbohydrates to get insulin low enough to ultimately shift metabolism toward fat-based metabolism. And ultimately a shift away from more glycemic-based metabolism. And that can have a lot of therapeutic effects. I'm a big proponent that in the literature, it's very clear that low carbohydrate is one lever to pull, meaning just reducing carbohydrates lower than the average intake of the average American or European, or essentially less than 130 grams per day. That can be a very powerful therapeutic tool. It's used therapeutically in prediabetes, obesity, and a number of other contexts. But when you really see a reliable improvement in therapeutic potential of a diet, it's usually because they went to the ketogenic diet spectrum. Because of these other additional effects on insulin and glucose and elevation in ketone bodies, which you can't completely detangle when you're on a ketogenic diet, at least when you're investigating them. In order to really assess the individual effects of things like insulin, glucose, or ketones, you have to regulate them independently of one another using tools like SGLT2 inhibitors, exogenous ketone bodies, and other ways of regulating one particular compartment of the mix of metabolic changes to understand where's the therapeutic potential coming from. And in many cases, it's coming from all of them, not just one of them. So I've always, at least from the literature I have seen over the last 15 years on the ketogenic diet and or low carbohydrate diets, the ketogenic diet is a much more reliable way to induce the therapeutic benefits people think they're going to achieve when they lower carbohydrates. Whereas a low carbohydrate approach may be applicable for many people who don't want to restrict their carbohydrates as much, but it just appears to be a less reliable way of achieving those same therapeutic goals based on what I have observed, based on the weight of the evidence. But you're asking someone to reduce carbohydrates even more, and that might be an issue for some people, particularly as the vast majority of people are not consuming low-carb diets. The vast majority of people are consuming somewhere around 45% of their total calories from carbohydrates. And that's really more like a moderate carbohydrate intake for a lot of people, which is, i.e., the Western diet. The Western diet is not a high carb approach. It's high carbs on top of high fat, which is actually more like a moderate carb approach. That's kind of these middle ground where it's this obesogenic diet that puts people at very high risk for metabolic disarray and dysfunction. The combination of excess levels of fat on top of excess levels of carbohydrates certainly can induce a not so optimal acute phenotype. Whereas the two ends of the spectrum, very, very low fat and high carbohydrates, i.e. like a vegetarian or vegan diet, has all this literature around its health benefits, although there are caveats to that diet. And there's all these health benefits associated to very low carbohydrate but higher fat diets, like a ketogenic diet, because the body seems to be very good when you give it a disproportionate level of fuel from one of these other categories. But if you mix them all together, particularly in sedentary individuals who are not very active, and they overconsume it, that can certainly place people at risk for things like dysglycemia and insulin resistance.
And when you talk about mixing them together, is that more within one meal, within one day, or in a more general perspective?
Yeah, that's a good question. Usually when someone talks about that, they're talking about just the literature. What I'm talking about is the literature as a whole that looks at the composition of a diet as a therapeutic intervention. So that means over a multi-week period of time, the average consumption of a certain ratio of carbs to fat and protein. But there's individual acute nuance to that, right? So if someone were to consume carbohydrates on a very low fat or a very low fat environment, people tend to, at least assuming they have normal metabolic health and they're physically active, can metabolize those carbohydrates normally. Well, there's been a number of studies where someone infuses fat into individuals and it induces insulin resistance. But these are all on the backbone of high carbohydrate-based approaches. Okay, so insulin infusion on the backbone of a high carbohydrate approach can induce insulin resistance very reliably. And so that's probably not a good move, right? However, if you look at bodybuilders or high-level elite athletes who don't have a specific use case for lower carbohydrate or very high carbohydrate, low fat, they're usually consuming a mixed diet of fat, protein, and carbs at a ratio that would be seen along the lines of a more Western diet with a higher proportion from protein. However, these are very unique cases where individuals are extremely physically active and erasing almost all the impacts that would be observed from any of these diets on a sedentary overconsumption environment. The reason a lot of these diets cause major issues is because they tend to cause people to overconsume them. The overconsumption leads to excess weight gain. Excess weight gain causes a cascade of risk. Look no further than GLP-1 receptor agonist data around what happens when you give these drugs that reliably induce weight loss. It seems to fix everything. Like you just look at the literature and Google it. They seem to, basically, fix everything, cure financial problems, make you mindful. Like, who knows what else they do? I don't know. But either way, what they're at their core, what they're doing is that they fix overconsumption. And so when people consume a lot of these mixed macronutrients, they tend to be at greater risk for overconsuming them. And that's why the Western diet has been termed an obesogenic diet, because a Western diet is a combination of many of these ingredients, but also can't ignore the fact that a lot of these are also ultra processed foods, which are specifically made to people at risk for over consuming them by no accident. These are like, if you can make a food right now, and like, hey, I'm going to make a food and I want that food to be consumed in mass quantities and be extremely enjoyable when you consume it. Make all ultra processed food, high fat, high carb, or, and who cares about protein? Like, just make that as low as possible, because that's expensive macronutrient. So just make the other one super high, sprinkle in salt into that. If it's like bacon, add just a little bit of sugar into it, because it'll make it that much more pleasurable, and then put people at risk for over consuming it. So,
all right, going really high level on the diet piece, eliminate the processed foods, prioritize protein, low carb or keto, depending on the person. You mentioned not eating when we're not hungry, so time-restricted eating. Any other foundational components before we leave the diet piece?
Well, Jess, I just want to say that someone can do a non-low carb ketogenic diet. Like, they can do a high carb, low fat approach, and that has been shown to induce positive benefits if you actually follow it. That's the key distinguishing factor, is that a lot of the reasons people follow low carb or ketogenic diet approaches, because there's a lot of literature that people inadvertently caloric restrict without effort. And so you could do this other approach. It's just if you can comply to it, right? So I would just say it depends on the diet, but ideally the diets that tend to be either low fat and high carb as a combination, or low carb and high fat, tend to be the ones that people can manage this best and more reliably. And the literature right now in diabetes says that low carbohydrate diets are the most effective at that lever of improving disease outcomes. So there's that just throw that caveat in there.
Right. And you're a proponent of low carb. So, but there is this other way. It's important to point that out.
Yeah, absolutely. Yes. And you can, again, it's all about what works for you. But so your question is, to what other pieces are beyond that? So what other pieces
seed
in the
oils,
diet are
other pieces within the diet realm that are being talked about or that come up for you when being prescriptive in a practical sense for people to regain metabolic health?
There are foods that have been described as, so I was going to go down the rabbit hole of talking about individual foods, but that's much more, we'd be here for 3 hours talking about food by food ingredients. I think when you think about what are the key pillars, it is truly focusing on a whole foods approach. The timing of when you may leverage those foods could be helpful for some. Although if you just do time restricted eating on a set prescriptive schedule versus not, just depend. Everyone's not going to respond to that. So it really depends on the person. Like, all this just depends on the person, right? But what would you pull beyond that lever? Those are the big ones, Jess. Like, those are the ones that have the most meaningful difference. Everything else is a very individualized circumstance. Like, do you eat this food versus this food? Do you feel great on this food or not? There's a lot of evidence that people, like some person, so Jess, like, you might be able to eat a bowl of ice cream and have normal glycemic response, whereas your next door neighbor may eat the same bowl and have a huge spike. And so that's where the individual nuance on how you respond versus your neighbors responding to individual foods starts coming into play. Like, and that goes down to specific foods. I don't buy into a lot of supplements or a lot of things outside of, diet. The literature is not super grandiose on kind of that level. But again, I focus on the big pillars, because the big pillars are what really move the needle. And it's the analogy of like the engine. the chassis of the car and all those other things before you put shiny rims on a car and a sound system. You got to focus on the big things first. But maybe for some people they like this, or a spoiler or some rims or some sound system or something like that. I don't know. But you want it to function, and so that's what I would focus on. I don't focus on a lot of these other factors. The seed oil conversation is an interesting one. I don't have much stake in the game when it comes to that. And also, to be frank, I haven't looked extremely extensively into where all this has arisen. I certainly have seen the origin of negative data around some types of seed oil, but there's also data that says that seed oils, if you just wipe the whole slate of all seed oils, that doesn't always seem to apply. It is particularly certain types of seed oils that, to my awareness, seem to be harmful. But either way, I don't have much of a stake in that. Although things like that are important, right? Like the type of fat you consume matters, right? You don't have a bunch of trans fat in your diet. That can have a pretty profound negative impact on your overall health. So yes, there are other nuances that matter on an individual macronutrient scale, like what type of fat are you consuming? What type of carbohydrates are you consuming? What type of protein you're consuming? The other things do matter. Like for protein, is your protein source of a whole protein, high leucine quantity form of protein, because that can help support muscle mass and recovery. These are things that get into the nuance of how you can start breaking down other factors that go well beyond just the things we spoke about. But a lot of things we spoke about here, Jess, were hyper-focused on weight regulation, insulin, and glucose. But there's a whole host of people who may not have to worry about that at all. At least maybe about like 25% of America or less. But the vast majority of people do have to care about those factors quite a bit. And actually, the overwhelming majority of adults, not overwhelming majority, the majority of adults over 21 years of age, data from over 10 years ago from the CDC has shown that I think it was 51% of adults had prediabetes and 80% didn't know it. So when we talk about most human beings in the United States of America and developed worlds, they need to worry about these things. But there is other individuals who are now the outliers, the non-majority individuals who are healthy, have no issues whatsoever, and they may have more liberty in what they do and don't do in their diet, but they do have to be careful because there's a lot of barriers in society nowadays that place them at risk for the same challenges everyone else is experiencing them. And so they shouldn't get lazy along the way and assume, well, I'm normal body weight, I don't have to worry about this. Maybe you should track all your internal health metrics over time. See if you're trending in the right direction. Do you feel great? Do you even know you feel great? Like, how do you know what great even feels like if you haven't tried anything else? That's where a lot of people use the term biohackers or self-optimizers. At first, when that term came out, I kind of laughed, but there's utility to it. It gets people jazzed up about trying and optimizing certain things, and I'm all about that. So I'm certainly a self-experimenter on many fronts, and like to do so all the way to the point of 10-year self-evaluations on dietary interventions and lifestyle, and actually try to go so far as to publish it and get it out there. So I'm all about it. But there's a lot of nuance in there, Jess. I focus on the key pillars, but there is individual nuance beyond that. If you really are worried about the things that are a little smaller, like less than 10% impact, less than 5% impact, like what type of protein do you have? What type of fat are you consuming? If you are going to consume carbohydrates and do so in high quantities, what type are you consuming? Are they high glycemic or low glycemic, or glycemic index? How much fiber is in that? Because fiber is another component that can be important for producing butyrate in the gut, and which can have an anti-inflammatory effect, just like beta hydroxybutyrate, a ketone body, can do. So yeah, there's a whole bunch of nuance to overall optimization of health that are important. But yeah, we'd be here all day just talking about and those key components. But yeah, fiber, type of protein, type of fat, they all matter.
Take me through a typical day, what you're eating, when you're eating.
I do not recommend anyone do what I do. But in full transparency, what I do is I wake up and I'll have coffee. I typically have heavy cream. I'll do I did remove all sweeteners for a period of time, but I found it had no real meaningful impact. And it definitely reduced the flavor of coffee down to dirt. So I do have 1 drop of stevia, a little sprinkle of salt into that. And I'll just ride that out. I'll focus on getting my sons ready for school, getting them to school, then working. Sometimes I'll wake up usually well before they wake up. So I'll start work early. And then when they wake up, focus on getting them transition, getting them to school, come back to work. And I'll just ride out the day until I get hungry, or I work out. So I try to work out every day. And so I don't know what that time typically would be, but sometimes like I like now it's like 2 p.m. Eastern Standard Time. There's a lot of days where I forget I didn't even eat. And this is talking about someone who used to be obese as a kid, right? Struggling with food. And so this style of diet that I do now has really empowered me to not worry about a lot of these things and focus on other factors in life. But I'll just ride it out until I get done with work. And then I'll exercise. I'll eat afterwards. Sometimes I might eat before, but I'm not a big fan of that. I don't like the idea of, I found that it's particularly in type 1 diabetes, if you introduce food right before exercise, it's a much more reliable way to introduce risks to dysglycemia during exercise, which can impair how you feel and your performance. So I'm just not a fan of introducing that. Why do that? So sometimes I'll have it before, but most of the time I'll just try to go exercise whenever I'm done working, or I get to a stopping point where I want to clear my head. I'll exercise. When I'm done exercising, I will have some type of high quality protein source, at least 50 grams of protein with a fiber source, typically from green leafy vegetables. And it depends on the day, but I might have a lot of fat with that. But sometimes I don't have a ton of fat. It depends on how I want to feel afterwards. Am I going to I need to have a lot of alertness and be really cognitively intact. Then I typically like to have lower insulin load because I feel better. I feel more alert. So I'll be careful about how much protein I'll have. I don't have like 100 grams, like I don't have like 200 grams of fat with that meal. I try to be somewhat judicious about what I'm doing and then focus on having my heavier meals later in the day when there's less consequences afterwards, besides just going to sleep. I don't have to worry about feeling sleepy or lethargic along the day. Then I'll focus on other things in life, right? That I'll focus on getting my kids home from school, focusing on my family, and then dinner. So dinner is the biggest meal of the day for me. And that's where I just kind of eat ad libitum. I don't really think about it at all. I just make sure I have enough protein with that meal, at least 50 grams of high quality protein, usually a lot more than that, with at least, a decent amount of fiber, at least 10, hopefully 25 grams of fiber with that meal. And I don't worry about calories at that meal because usually my body will tell me how much I need to eat. It's been able to self-regulate at this stage in my life and this metabolic health journey. And then that's it. I try not to introduce a whole lot of food beyond that because I don't want to introduce a whole bunch of excess meals and overthinking, I need to have this dessert or that dessert. I found that higher food frequency was not necessarily beneficial for me. I found that less food frequency actually worked better for me. I didn't think about food as much. I wasn't on the clock for food. I just ate food whenever I felt like I needed to or it was important for exercise recovery. I find some of the greatest freedom, honestly, in life for me is going a pretty extensive day without eating at all. And that sounds like absolute torture to many people. They're like, it sounds horrible. Why would I ever go a whole working day without eating? It's freeing. It's so freeing to not think or care about food and just focus on other things in life. That some people would say, well, that's so restrictive. You didn't eat all day. I'm like, no, like that's freedom. That's freedom away from food. That's freedom away from worrying about insulin or glycemic dysglycemia. That's freedom. And I don't do that every day by any means. It would be hard to keep up any body weight and recover to exercise the way I'd want to. So I typically try to get at least 2 to 3 meals in a day, but I don't think about it, man. My priorities are not being the biggest, strongest, fastest of all time. It's optimizing my overall health to achieve being as big and as strong and as fast as I can be while prioritizing things like my family and work over all those other factors. Because that's the priorities I have in life. And so each person might have a different priority structure, and they have to focus their nutrition around that.
All right, as we wrap up here, your health pillars: diet, which we went deeply into, sleep, and I want to end on this, exercise, and tying this into metabolic health, the advantage of having more muscle mass on the body in relation to insulin resistance, diabetes, metabolic health, and the advantage there.
Well, it's very clear. I mean, there's a ton of people who made entire reputations and namesakes and brands around higher muscle mass and retention. Look, we've known for years that higher muscle mass is important for overall health. The reduction of muscle mass, this is actually part of what I studied in my graduate studies, is actually looking at diseases that result from lower muscle mass, cachexia, sarcopenia, and beyond. Yeah, the data is overwhelming. Like the higher your muscle mass, the lower your risk for chronic disease. And protein has an important component in that, but the most component in maintaining muscle mass is not protein, it's exercise. You actually have to use that muscle. That's the most important thing. Protein is microscopic in comparison to the importance of exercise in maintaining muscle mass. So resistance exercise is the most important component of that. And it's not just about metabolic health either. It's actually about the retaining key muscle tissue that has important it's an important metabolic sink in the context of longevity. So as you age, you tend to reduce your muscle mass. So having higher starting amounts is good, because the trajectory, if you ever look at age-related muscle mass, you see this curve that goes down over time and has these short blippets of fast deterioration, usually because of inactivity, or what they call deloading in scientific literature. And ultimately, one of the key risk factors at end-stage life, so in older adults who have gotten to an advanced age, one of the most important predictors of longevity is muscle mass. But actually more important than muscle mass is function, because the function of that tissue is actually much more relevant to actually staying active and mobile than the actual mass itself. Most people have a reasonable level of mass unless they have disease or they're at a very advanced age where this is a pertinent issue. But beyond that, some people want to look jacked too, right? Like there's a physical component to all this that's really important. So people want to retain as much muscle mass just to look and feel better. But usually muscle mass is associated with higher function. So usually if you work that muscle, it gets larger and it becomes more functional. But ultimately you have to load the muscle in a progressive manner while also being safe chronically over time to allow the muscle to adapt to become stronger. And those are key principles of maintaining muscle function and mass. And yes, muscle mass is really important. The absolute amount of it, though, you don't need to be a bodybuilder to have optimal health by any means. You just need to have enough, and you need to use it. One way in which using the muscle is so important is we know that it can actually increase insulin sensitivity sometimes up to 2 days beyond it. And we know that there's so many more other benefits beyond insulin resistance, anti-inflammatory effects, all these other effects from exercise. You feel better, cognition effects. These all these reasons you should exercise. Everyone should exercise. There's almost no exception to that rule unless you literally can't. But even there's been studies on heart failure that high intensity interval training under clinical supervision is actually very good for overall health and outcomes. So even in cases where you think you shouldn't exercise at all, that you might die, the literature is now emerging that even those people should be exercising.
Andrew, I know I got to let you go. We're going to link up your website, your social media, everything in the show notes. Really enjoyed this. Thank you.
Jess, you're the man. Thank you. Appreciate the opportunity.
Now that you're done, you're going to want to stick around here and catch this other incredible episode. You don't want to miss it. I'll see you over there.
88% of American adults have some degree of insulin resistance. High blood pressure is an early sign of insulin resistance. Fat gain, obviously, difficulty losing weight, brain fog or fatigue.